So for the families to get used to the term, how would you describe to them what is a polyp?
Good question. A polyp is a growth. It's like a wart, like something grows in the nose, in the face, but in this case, in the lining of the bowel. The bowel has many places. You can have polyps in the mouth. You can have polyps in the pharynx, in the vocal cords, and in the swallowing tube, stomach, and small bowel and large bowel. At any one of those places, you can see polyps.
So welcome to our first review about topics on pediatric gastroenterology. We have a guest today, Dr. Reeves-Garcia, which I'm very proud to introduce. Or expands on my career. He was very influential on my own career, and actually he was a mentor of mine at the beginning of my career as well. Dr. Hernandez. I'm one of the gastroenterologists and with Pediatric Gastroenterologists Associate. Jesse, just to kick in, you just give us a brief introduction about yourself, who you are, and how you got here.
Hi, I'm Dr. Jesse Reeves-Garcia. I'm a board certified pediatric gastroenterologist, and I've only been here for 37 years since I graduated in medical school in 1982 in Puerto Rico, where I was born and raised. My interest in pediatric gastroenterology was because there's so many things that we do in this field. And in particular, endoscopy was one of my interests in teaching, and also cholestasis in newborn, but just to find out what it is, and then I give it to you and my other hepatologist friends so they can follow from the liver point of view. It's the diagnostic challenge, what is exciting to me. And in endoscopy, polyps is a very important thing. And that's why today I think it's important to discuss the issue of polyps in children. All the adults at 50 years of age will have a colonoscopy or should have a colonoscopy. And what they're really interested in doing is they're looking for colon cancer, but the predisposition to that is having polyps, or to recognize polyps, get them out so they don't turn into cancer. But in children, we don't do that, except that if children have rectal bleeding, one of the most common causes are colon polyps, and it's a benign condition, but in rare cases it can be malignant, and in rare cases it can be troublesome because it has a lot of consequences. So
So
today
for
we're going
the
to talk
for
about
the
that.
families to get used to the term, how would you describe to them what is a polyp?
Good question. A polyp is a growth. It's like a wart, like something grows in the nose, in the face, but in this case, in the lining of the bowel. The bowel has many places. You can have polyps in the mouth. You can have polyps in the pharynx, in the vocal cords, and in the swallowing tube, stomach, and small bowel and large bowel. At any one of those places, you can see polyps. In general, painless rectal bleeding, single isolated polyp is one of the most common things that you're going to see as a growth, inappropriate growth in somebody. In children, and it's usually benign. Some of them are more troublesome, and some have consequences that need to be followed, including the risk of malignancy and surveillance. So that's why we have to make sure that if we have a polyp, track it down, get it out, and examine what it is, and make sure there's no other sequela consequences or other risk factors associated with it.
So polyps is something that would you see relatively frequent in pediatrics, or is something that you see rarely?
Actually, it has two peaks. The main presentation in one of the most common pediatric tumors is isolated colon polyps, and that can happen at first 3 to 5 years of age. Then it goes down in frequency and shows up as an adult. Around 40, 50, you got to do follow up and make sure that people don't have polyps. That's why you do surveillance colonoscopies, trying to avoid colon cancer.
And when you say tumor, you refer more to a benign
In,
type of
in
tumor.
pediatric cases, 99% of them are benign. In 36 years of my career, uh, I actually had picked up two colon cancers that I personally dealt with. I've seen five in my career of adenocarcinoma of the colon. But the more important thing are syndromes or conditions that are associated with polyp formation and that can lead to cancer. And I've seen over 20 of them. So I had a particular interest in polyp, and I actually did a grand rounds of a major presentation about this to review all these things, review all the images. It happens to be that I've collected images and videos of all these conditions over the years.
So ground round means that you discussed this topic, or you presented these topics at a hospital that was at Nicholas Children's.
I did at Nicholas Children, and the idea is that when you do that type of presentation, you go in with all the data, all the articles, all the descriptions, all the presentation, because it's a format that you're going to review for others and for the physician what it is, and you better be sharp and know what you're doing and do a very honest and straight up presentation. It's a very significant and an honor because it requires a lot of effort, but it also makes you review all these things. And happens to be that I got copies of all those. And I was interested because I hated polyps, because I did not have control of all the nuances and conditions. And now I feel like I have that control.
David, Jesse, before diving into the different classifications, so let's talk a little bit general about uh, how early can you start seeing polyps in kids, and what would be the type of polyp that you will see in this age group?
Remembering that polyps is just like a wart or a growth. And it actually been described as one of the most common growth or tumors or polyps, benign usually in children. Anywhere, if you have painless rectal bleeding, that's a main clinical clue. Blood in the poops that's not associated with constipation, with big stools, with diarrhea, with fever, with anything else, just blood in the stools, and there's no hemorrhoids. Most common cause of painless rectal bleeding is a polyp, anywhere in the first 3 to 5 years of age. Have I seen polyps earlier? Yes, I had. I've seen several kids who had polyps starting at 2 months of age, and I took 28 polyps on a kid who was only 6 months of age and had anemia, had all these polyps because he had a underlying condition that triggered formation of polyps. That's extremely rare, but there's several classifications for them. The most common one is painless rectal bleeding and a normal, happy Peter who's doing fine, and when he poops, there's some blood and there's nothing else. And we look for infection, any other causes, and if not, we take a look with a special camera, and if we see a polyp, we take it out right then and there. But the important thing is to take it out and retrieve it and look at it in a microscope to make sure it was an isolated single-time thing and that there's no risk for other things in the future. Usually, you don't have to do surveillance if you have something called amartomas, which is benign polyp in the colon. You take it out, it's over with. If it's a different type of polyps or more than 5 or 7, that's a whole different ball game. You have to follow this kid for life and do a series of things to make sure they don't get into trouble and surveil for other conditions that can be associated with that. That's what they call it, polyps syndrome or polyposis syndromes in general.
So, so let's say that you are seeing a pediatric patient between 2 to 5 years of age, and they come to see you because that kid is having a blood, he's pooping blood. And let's say in this case, it's going to be, we call it bright red blood. So it's fresh blood. And the patient doesn't have any symptoms at all, no pain as you described. He's growing well, he's eating well as well. So if it's something recurrent, regardless of the patient having or not having anemia, you would recommend doing a colonoscopy.
I actually recommend looking at the child from top to bottom. Make sure there's no freckles on the mouth or the inside of the mouth or hands or genitalia. Make sure there's no infections, no fever, other things, other causes. And unfortunately, if we don't find a cause for bleeding, like an infection, C. difficile, then we do recommend taking a look, because if it's a polyp, get it out. One more clue: there's a blood test, a stool test now called calprotectin, that if it's elevated, it means polyp, tumor, Crohn's, or colitis. And it's another clue that we have that we didn't do before. And it's important because we can actually take a look without much pain or discomfort. And if it's a polyp, get it out, get it over with. But you got to retrieve it to make sure that there's no significance on the road on that.
Yeah, so that's a good point. So you don't jump right away and doing an endoscopy or
No.
colonoscopy. You
No.
do a physical evaluations, taking a good history
Exactly.
through the family, so to the kid. And then usually we perform some panel of tests that would include stool tests and blood tests to check for other type of conditions, like you say, like infections and so on. And then if we are not able to identify what the cause is, So then, and the problem continues. So that's it's when the indications for
Right.
colonoscopy.
Since we're a referral center from all South Central America, I have on my presentation showed up a child who was 2 years old, had been bleeding on and off for a year, and they did a computerized tomography, a CT scan of the abdomen, and showed a mass in the colon below the liver. And they came to us thinking it was a tumor. No, it was just a polyp. But because they didn't have in the country where the child was, they didn't have pediatric gastroenterology do this type of procedure. We just went in, took it out, and get it over with all in one thing, and that's fine. The problem the child was for a year with rectal bleeding, did not get anemia. But nowadays, if you don't have an answer, they do imaging. But most of the time, if you have gastroenterology present, all the workup is negative for a special test. The most efficient way, take a look. Because if you see it, you take it out right then and there.
Yeah. The colonoscopies are safe to do in kids.
Colonoscopy incredibly safe in children and adults. Of course, you're board certified, you're trained in this system, you have an anesthesiologist who take care of the kid. Different than they do in other countries where they don't do sedation, anesthesia, stuff like that, like Cuba and others. No, we actually have a health specialist take care of the child, make him comfortable, make him sleep with a medication through the IV. They don't need to be intubated, don't need to be general anesthesia. No, sedation. They put them to sleep, and it's the best sleep they ever had. And after they've been cleaned out the day before, medication we prescribe, and then we use a tiny camera to go look inside. And if we see a polyp, we have the technology to take it out right then and there. No need to any type of operation on the outside or anything. Just endoscopically, you take it out, put a wire around the polyp, pass electricity so you can cauterize it, and then resect it, take it out, grab it with a special snare that we have, and retrieve it and send it to pathology. The important thing, send it to pathology to see what it is, make sure there's nothing else bad. 99% of the cases is an adenoma, is a benign thing. You take it out, it's over with.
So most of the time you're going to be able to take care of these during these colonoscopies and being able to identify the polyp and get it out. That's what we're dealing with.
Exactly. And actually, when we say consent for colonoscopy and biopsy, looking for tissue, if I see a polyp and did not get consent for polypectomy, we start the procedure, go outside, tell the parents, hey, look, we found a polyp, there's a picture, let's get consent to the polypectomy, we just take it out. The risk is minimal because it's not significant. The only thing is that 4, 6, 8 weeks later, in 37 years, I had 2 kids who has been described before that bleed 6, 7, 8 weeks later because the area of the polyp, the clot becomes weak and bleed, but that's extremely rare. It's a risk, it can bleed. But 99% of all the children, you take it out, is nothing out of the ordinary. And the bleeding can be controlled it goes away by itself. You can put a clip, and it's not a contraindication. It's a simple procedure in the right hands.
So important thing is at the time that you remove the polyp, make sure that you don't leave behind bleeding.
Exactly.
That it may affect the patients
exactly.
Hours later, so a day later, and so on. And then if the patient bleeds during the procedure, so there is a way that you can control the bleeding and stop the patients to bleed.
Absolutely. We have technology we didn't have 30 years ago, which is just put an endoclip. And 20 years ago, 15 years ago, we actually have a loop that we put in to be more secure, but we don't need that anymore. The technology, the techniques, the instruments are incredibly effective and high resolution, so you can see what you're doing. And if you train properly, when you take the polyp out, the risk of bleeding is incredibly low because you're trained not to go too far down and trained to follow that closely and monitor and look at it afterwards. And it's really a very safe procedure.
An endoclip is a meta clip.
It's a meta clip.
That you clip the area of bleeding, not the polyp. The polyp is already out.
And the area of bleeding, and it's like putting
a staple.
And then
the patient can expel the clip by itself in a few days.
In a few days, no need for intervention.
Okay. So let's say in terms of the amount of polyps that patient has. So my understanding is that you can have only one polyp, a single polyp, throughout the whole colon, or you can have multiple, something that is less than 4 or 5 polyps, or you can have several, more than 5 polyps.
You're absolutely correct. The important thing here is in more than 90% of the population, you're going to have one polyp. But we train all our residents, we train all our GI fellows, we train all our endoscopists that if you're going to do a colonoscopy, do the whole colonoscopy. You find a polyp, you do a whole colonoscopy, and on the way back, you take the polyp out because there's a 5 to 12% of people who have more than one polyp. So if you're going into the colon and find a polyp in the lower part and you take it out and say, that's it, you may have had 2 or 3 further down. So at least the first endoscopy, you got to go all the way through, make sure everything is okay. On the way out, you take the polyp out, and if it's one, that's it. If it's more than one, you got to make sure that there's no more, and more important, that you get the tissue to see if this kid at risk of having recurrence, or if it's an isolated thing that happened once and that's it.
Now, can you tell us a little bit more about what is a polyposis syndrome,
Mm-hmm.
and when you get into this diagnosis, and what would you do?
The polyposis, again, like I mentioned before, the most common thing is a single polyp, a hamartoma, and then just a wart, take it out, get it over with. But there are cases that there's more than one. If it more, and depending on the type of polyps, you got type of polyposis syndrome. For example, the so-called hamartomas, the same as the single polyp, if you have more than five, you got a polyposis syndrome. Does that increase the risk of cancer? Not dramatically. But you need to follow that kid closely, and you need to do special tests, genetic tests, that says this person is at risk of this problem, because you got to do certain follow up for those things. If you have more than five in each hematoma, that's what you do. You can have polyposis that the polyp is made out of a different type of tissue, something called adenomas. And if you have more than one adenoma, two, three, four, it can be hundreds. Then you got to ask yourself a lot of questions. For example, on the exam, do they have freckles in the mouth, in the hands, in the feet, and so the feet? Because that's something we call Peutz-Jeghers that has a whole different series of consequences of the type of polyp that they have. And it's important to remove those polyps, look at them, because they'll tell you it's Peutz-Jeghers. You got a whole different thing, because after they become adults, after 20, 30, 40 years, they get all type of problems and cancer and stuff. But as a kid, they can get obstruction in the bowel and others because they have multiple, and you have to present that, follow that, and take care of that closely. And a genetic test will help you.
So now we are dealing into this polyposis syndrome. So you scope the patient, you remove some of these polyps, and then my understanding is that the pathologist can let us know only through biopsies under the microscope.
Mm-hmm.
It the classification of that polyps, that it can
Exactly.
be usually hamartomatous polyps
Mm-hmm.
or hamartomas,
Mm-hmm.
and there are type of polyps that we call adenomas,
Mm-hmm.
and that's what it will lead into more kind of the differential diagnosis onto the type of polyposis
Right.
syndrome that we are dealing with. So in terms of the hamartomas, and so you say that we have a Peutz-Jeghers.
Then we have another classification, so-called PTEN, which is two types: banana, rice, walcaba, and the others. That, remember I mentioned a kid that I had that was 6 months, had 28 polyps. Well, I took over 60 polyps on the child, but because anemia, we took part of the colon out and leave him alone, and he's gonna be fine. There's no problem with the colon. The problem is that they have other anomalies. They have high risk of breast cancer, high risk of other things that need to be surveillance. You have to look at the thyroid at 8 years of age, and after that on every other year basis, and colon cancer after 35 years of age. If it's and you have genetic test that says it's PTN, on exam you get freckles in the genitalia, freckles in different part of the body, and several characteristics. Then you have the other type, which is generalized juvenile polyposis syndrome, which is hematomas in different part of the body: stomach, small bowel, rare, and colon. And they can have hundreds. In that one, there's no particular medical therapy, but you got to control the anemia, control the load of polyps, because depend how many they have, and also monitor them, because and there's a genetic marker that can be seen to diagnose that child, and then be specific for what risk do they have when they become older as an adult.
So usually, if I'm clear on this, so now you finish this colonoscopy, you see several polyps distribute to the gastrointestinal tracts of the patient or the colon,
Mm-hmm.
and now we are more intrigued about the issue of polyposis syndrome. I believe that even before we get biopsy results, you send genetic testing
Absolutely.
to T cell
Mm-hmm.
the type of if there is any mutation linked to the polyps, because that would give you, my feeling is, some kind of prediction in terms of outcomes and things like that based on the type of polyps, on the histology,
Mm-hmm.
and the type of mutations, and then looking for extra intestinal manifestations of that polyp.
Exactly. And then I did mention some of the ones that are usually seen with the benign polyp, the hamartomas. That's fine. And then the risk of cancer is a Peutz-Jeghers causes obstruction in the bowel every now and then, and you have to monitor for that. That's a whole different thing.
And the obstruction, before you keep on going, so meaning that that outgrowth of tissue in the colon can
Or
be a lead point
in the small
towards
bowel,
in the
in the
small
small
bowel.
bowel, and that can cause obstruction, and the gut gets literally the gut gets plugged, and may need surgery. And we try to avoid that by monitoring on a regular basis, and if needed, taking out the polyp before they get to be too big. But that's if you already know you have freckles in the mouth, you have multiple polyps, you have the polyp type is Peutz-Jeghers type of polyp. Genetic test is positive for the genetic marker for Peutz-Jeghers. And then you got to do a series of things and explain to the parents on a yearly basis. This child going to be evaluated on a yearly basis. The child going to get all type of procedure, including capsule endoscopy, that can look at the small bowel and look for polyps. It's a capsule endoscopy. It's a fascinating technology where you use a tiny little. It's actually a big pill that has a camera, light source, battery, and sends a picture every 2 seconds. You swallow it by mouth with a glass of water, and they look at the whole small bowel without having to sedate, anesthesia, and stuff, and takes images and then identify this polyp somewhere and then do that in that setting, rather than being invasive with endoscopy. But the other thing is, there's another whole type of polyp, the so-called adenomas. If you have more than one, and the consequence of that one is very, very different. And we need to know the diagnosis because there can be severe consequences. For example, if you have familial polyposis, which has a more, it can have hundreds to thousands of polyps in the colon, these people can have a risk of colon cancer by 35 years of age. And we got to do surveillance on the children. You got to do surveillance on the offsprings. You got to look at the babies of those parents that can have a liver disease, hepatocellular carcinoma, hepatoblastoma. And there's a lot of things that need to be followed and monitored for those conditions because that's a whole different ball game. It's not just a simple polyp that is okay. That's high risk of something that down the road, as the child gets older, can get serious problems and consequences of colon cancer in 100% by the time they're 50. So we have technology to find that out in
So
time
you always try to remove when you see multiple polyps as much of polyps as you can
within
within the
within reason.
one procedure.
Within reason.
And then the so it would be more worrisome that prognosis if the patients, instead of having a hematomatous polyp, they have an adenomatous
Right.
polyps.
Right. In adults, they're looking for polyps. If it's a hematoma, they take it out, no big deal. If it's adenomas, risk of cancer, so they get another colonoscopy sooner.
But even having a
Mhm.
hematomas or an adenoma as a
Mhm.
histology of polyp, it doesn't mean that the patient has cancer.
No, 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 no. It does not mean cancer. A risk down the road, depending if you have more than 5 polyps, you need to make sure what's going on with this child. More than 5 polyps is not normal. Okay to have 1 or 2 polyps. That's not a big deal. That's not a serious consequence. We're not going to do endoscopy every year or stuff like that. If it's adenomas, you may ask yourself why you have more than one adenomas and how come it's happening. In 36 years, I found 2 children who had adenomas at 10 years of age. I took it out, went back 3 years later, there's nothing there. If it's one, no big deal. But if you have 4, 5, 6, more than 5 polyps, by definition, you got a polyposis. You got to examine this child thoroughly from the top to the bottom. You got to do genetic testing. You got to find out, get the tissue of those polyps. You got a list of things, and I have a big graph of what to look for this condition, this for this other condition, that, and do the best you can to make sure you can take care of these kids.
So now they again, I mean, based on the history, family history, personal history of the patient,
Mm-hmm.
histology of the polyps,
Mm-hmm. Right.
and genetic testing for the polyps, we can predict and lay down to the
Mm-hmm.
parents
Mm-hmm.
of the patient the follow up, how often the colonoscopy is going to be done, and if we had to test for any
Mm-hmm.
other extraintestinal manifestation of the polyp.
Absolutely, very good point. I had a kid from Ecuador who I followed for reflux, and I look on upper endoscopy, had a couple of polyps in the stomach, nothing else. But then, 15 years later, now the child is 19. Um, the father was found to have multiple colonic polyps and something called MUTCH mutation, and that's a whole different bad condition because they have all type of risk of colon cancer, gastric cancer, thyroid cancer, breast cancer, testicular cancer, and they have to do all type of things starting at 35 years of age. But the point in this particular kid is that mutation is autosomal recessive, meaning you have to have both parents to have the MUTYH mutation. My patient only had one. So since he was out, he's autosomal recessive, but he only had one. He was heterozygous. That meant that we don't need to do endoscopy every year, ultrasounds every year, all these type of things, etc. We spared him from doing all these type of things.
Did he had any polyps too, or
He had polyps in the stomach and did not have polyps in the colon. So we spared him from having to be evaluated on a yearly basis for the rest of his life with colonoscopy every year and stuff, and the risk of cancer over his head because the mutation was heterozygous, one not the bad one. The father has a full blown thing, but the child doesn't. On the other
so he
hand,
was kind of a carrier
his
of that
ex,
abnormal
ex
gene
and
that I believe that that's being associated to Lynch syndrome. That's what people
it's
call
a
it.
similar category for Lynch.
Yes.
Because Lynch has all these other things after 30 years of age. But in this one, the MUTCH, I think is the worst one of all because they get all type of cancers of all type
Yeah.
of the body, and you have to do all type of procedures on a yearly basis, and the risk of cancer on the back of your throat. This child didn't have it, so we spared him from doing all type of evaluation. On the other hand, I had a child a young man who was 18. The colon was full of polyps. He had familial polyposis. APC gene was positive, and we told him you have a risk of have to do all these things every year. You have to do all these things. You got to follow every 2 3 years, and it's autosomal dominant. Your children, 50% of children will have it. Unfortunately, the child decided to have two girls. I saw one of those girls for abdominal pain. I did an endoscopy, and she already had polyps in the stomach and polyps in the colon and has the same disease as the father and the other girl also. So they're now exposed to having colon cancer by 50 years of age,
Because this is autosomal dominant.
dominant, and by knowing what it is, you have a series of things to follow, and you tell them what the risks are, and you tell them genetic counseling to avoid this problem because it really is a problem. Okay, and you need to know which one is it. But if you look at the two girls, they're absolutely gorgeous, beautiful girls. But because I knew the father had this polyposis, I did endoscopy on purpose, did it lower. I found at 5 years of age, I found 5 polyps in the colon and 7 of them in the stomach. And we know this girl, by the time she's 13, 14, we need to do a surgical procedure to avoid the risk of cancer.
Now, in the past, there has been medical treatment described to prevent or decrease the size of polyps or prevent the appearance of new polyps in these polyposis syndromes. I remember that one of the treatments described a while ago was
Right.
the COX-2
The COX
inhibitors
inhibitors.
or the colexibib.
Yeah.
And other treatments ask for like immunomodulations and so on. So it's anything new in terms of medicines on these polyposis?
Unfortunately, the problem is because there's relatively rare, 1 in 5,000, 1 in 17,000, to be able to get a randomized prospective study on using a drug to see if it prevents something, and then realize that you're trying to prevent cancer, so you do the study where you're going to treat some, you're not going to treat some, and see if it makes a difference. But when you're dealing with cancer, it's hard to say. So there's no good controlled randomized study that says, or there's no policy, should I say, from the Pediatric Society of using anything to decrease at this time to prevent the risk of cancer, because there's no good answer. And if you miss it,
Yeah.
the
No,
risk
my
of cancer.
understanding was a small randomized study.
Uh-huh.
It was a small one, and you're exactly right. They didn't see any difference with the COX-2 inhibitors.
Right. And that was for familial polyposis, generalized juvenile polyposis.
They
Of
saw,
which,
I believe, it decreased the amount of polyps the first year, the first 2 or 4 years of using the
Mhm.
treatment compared to the patients that were not on treatment on
Mhm.
placebo.
Mhm.
But after 4 or 5 years, it didn't make any difference.
And
So really, there is no medical treatment for this.
and people are seeing some association of the use of aspirin, decreasing the risk of polyps, weight, the diet. If we can change the diet to a more normal, less processed foods, more fiber, Mediterranean diet like type of thing, you may decrease the risk. But you have a familial polyposis genetic disorder that says if you the odds of having cancer or something serious by X number of years with this disease is so high that requires your doctor to take a look at you regularly. We cannot say by doing this medication you're going to avoid doing that. You may use it if you want to, but it's not a standard recommendation
Yeah, I
right
wanted to ask you
now. Mm-hmm.
something a little bit about the diet. Before we get there, my understanding also is that I believe the use of these Celebrex or COX-2 inhibitor came up after the use of adult patients being used aspirin
Mm-hmm.
as a prevention from a cardiovascular event,
Mm-hmm.
and they saw that patients who've been taking aspirin with polyps, they have less of that in the future. But again, I mean, there is nothing that in pediatrics nowadays that it
Mm-hmm.
says that this patient needs to be exposed or long term to aspirin, so anything like that.
Exactly.
Now, in kids with polyposis syndrome, does having a healthy lifestyles or a healthy diet, do you think that that will help them or in any way?
That is the new recommendation for the recent meeting for inflammatory bowel disease, and it makes a difference in Crohn's. May make a difference in colitis, unfortunately, because polyposis syndrome are rare diseases. We don't have a full blown recommendation, even though it has been shown to be more commonly in developed countries due to processed foods, and we don't know if it's microbiome and the others. So I don't have I like to use the standard recommendation for the European Society of Pediatric GI, the American Academy of Pediatrics, and the others. There's no standard recommendation right now about diet. We do know that for the now new recommendation for inflammatory bowel disease is to try use a Mediterranean diet or avoid refined foods, avoid red meats as possible within reason. I cannot say that for polyposis syndrome because the odds here is in a severe polyposis syndrome like familial polyposis, juvenile familial polyposis, like METYCH, like GAPPS, which are names of different polyposis syndrome. Um, the concern is cancer, and it doesn't make you already have the polyp, so it's not going to make a difference in terms of decrease in frequency because you got a genetic disorder that makes you predisposed to have these conditions. In general, though, for healthier gut, healthy microbiome, healthy avoidance of routine polyps, which is the adenoma that happens, what is really recommended is a healthy diet, high fruit, high veggies, and low refined foods. But for polyposis syndrome, we don't have that
Yeah, I agree.
recommendation.
I mean,
Mhm.
our understanding now about our genome is not it's not written on stone, so
Mhm.
it's really changing often. And that it changes but the epigenomics and that it
Mhm.
changes by your diet
Absolutely.
and so regardless of nothing being concrete about polyps and diet, most of the times we would recommend the patients
Mhm.
prevent to avoid to excess of exposure
Mhm.
to Western diet or fast food or
Mhm.
refined type of food and so on and so on.
And exercise and it's a general healthy diet. But then you got to go back and ask the history. If you have a father, grandfather, grandmother who had polyps and polyps and polyps, you are prone to have polyps. Whether you have symptoms or not, the important thing if you do have painless rectal bleeding, get checked. Your friendly gastroenterologist is not going to hurt you. They're going to try to figure out there's infections or anything else. If push comes to shove, you can do a one colonoscopy, and now it's so safe and effective. Uh, Complications 1 in 79,000, but in general are minimum. Um, and the idea is it's important to find out what you have. See, the colon is deep inside the human body. If you don't go and look, you don't see. If you do imaging, now you have imaging plus, you got to go in and take a look and see what it is and take it out. When you do endoscopy, you take it out right then and there if there's a polyp. You got to find out why the rectal bleeding. You got to find out why there is risk of rectal bleeding. And if you find the gene that is causing the polyposis on the father, the grandfather, or the others, then that gives you guidelines for your particular child or offsprings. And by doing those tests, you can avoid them from getting a lot of procedures because if a gene is negative, forget about it. But if the gene is positive at 8 years of age, 10 years of age, you got to survey the kid with polyposis. If they have any symptoms, don't be afraid of doing stuff early. Like I said, a 5-year-old that had already five hematomas, polyps in the colon and 10 in the stomach. And I know that by 15, 17, 18 years of age, we'll make decisions of things to be done. And it's important to just take a look and figure out what it is.
When would you recommend for your patient to be evaluated by a surgeon or having a surgery for his polyposis?
Is a very, very good question. In general, there are some genetic disorders that require polypectomy, surgical evaluation and colectomy. but you have to have a heart and you got to work with the family. What do I mean by that? Familial polyposis, familial polyposis syndrome is a syndrome that will cause cancer by 23 to 40 years of age and 100% at 50 years of age in everybody who has that gene. If the father and the uncle and some other relative had it and you have the gene and the child has the gene because you studied them and you have that, then you recommend endoscopy by 8 to 10 to 9 years of age, upper and lower endoscopy. If you do find polyps, the recommendation of taking the colon out is by 10 to 12 years of age. Or if the kid does not want to, I had a kid who did not want to, wanted to go to college, have the college experience, and do the stuff. Then we worked with him, and at 19 of age, he had the colectomy. And nowadays, they do surgery that you don't have a bag all the time, but rather they do in such a way that you can continue using your natural orifices. If you have a child like the one I had at 5 months of age with 20 polyps, at a year of age had 40 another 50 polyps, and anemia, then he had, and the type of polyp that he has were adenomas, hamartomas. So he had general polyposis syndrome, and he had, he had Banana-Riley-Barcava syndrome, PTN positive gene. So I told the surgeon, we're not going to cure the disease, we're going to limit the load of polyps and bleeding. And we did a partial colectomy. Only part of the colon was taken out. So that way it will be easier to do colonoscopy and less risk of bleeding because there's less polyps, which is what his father had done when he was older, but he didn't tell anybody. He did not know. Okay. So the surgeon had called when they're going to help us to decrease bleeding, severe bleeding, or too much of a polyp load. You can't do stuff in a thing that's not going to be colon cancer, like PTN positive colon polyposis, or general polyposis syndrome. We take part of the colon out so we can control the load and anemia. But he has specific disease, you got to take the colon out. There's two conditions come to mind, and I actually had both, a patient with both. One is where the colon gonna be full of polyps, and by 50 you're gonna die from colon cancer. You don't take it out, and you gotta take it out by a reasonable age, 12, 14 to 15 to 18 years of age. In there, work with the surgeons in the family, and the other one is extremely rare condition that I happened to publish the first Hispanic child that I saw at 16 with that condition that was first described in 2012 by two families in Australia and a large family from United States. And there's 27 families in the world with that condition, which is a girl that had abdominal pain, vomit blood, and I did endoscopy in the stomach. The upper part of the stomach was full of polyps. And the polyp was something called gastric fungal gland polyps. But the rest of the stomach and from the rest was normal. And I said, this is incredibly strange. I had never seen it. And I had done a lecture on polyps the year before. Happens to be it was only described 2012. This kid was 2017, and not in pediatric literature. It's adult literature. And I spent months with this thing, talking to pathologists and to others. And then we found, look for GAPPS. We sent to the NIH. We did the genetic testing. She had a modification of the gene called APC gene with same for familial polyposis of the colon. This is a familial polyposis of the stomach. And in this kid, the thing is this. If you don't take the stomach out by 20 years of age, they have 100% cancer, gastric cancer. Even if you're looking at every year, there's so many polyps, one of them will go into cancer. So this girl, 16, waited until she was 19, went to the NIH, had the stomach out, and she's doing fine by eating small. Like if you do a gastric bypass, she's doing fine, but she had to get her stomach out. After we documented that genetically, that's what she had, that the risk was so incredibly hard, and you cannot do endoscopy every year and stuff. So those are the two things you call the
So it was
surgeons.
kind of a modified type of familia adenomatous polyposis
Ex-
syndrome,
but
only involving the
in the
the
stomach.
stomach.
And there's 28 families in the world at the time of this, which is 2 years ago. We got published 2 years ago in the journal Gastroenterology. And she was the only female Hispanic. And she had a weird variant, but it's compatible with everything else. So we put it out so other people can recognize this and recognize this type of thing.
So,
And
so the patients of yours that requires a proctocolectomy or colectomy or partial colectomy, as you
mhm,
refer, how do they do after surgery usually?
they do wonderfully well in terms of you take away the risk of dying from cancer. You take away the rectal bleeding, anemia, anemia, rectal bleeding, anemia, uh, and you control the disease and you control the load of polyps. Like my Banyan Riley, we did the partial colectomy, and that's we were done 8 years later because he had no more pain. He had H. pylori,
Mm.
okay, and but he's doing fine. But he does thyroid changes that they need to be evaluated after 12. The PTN positive. Polyposis, they got thyroid, breast cancer, and others. I have three families with that same condition. Three girls, one boy, two girls, and you got to monitor them for but control the load. The children with colectomy, they don't have the risk of cancer. And in the Banana Riley, we took part of the colon out, so there's no need for transfusions or blood transfusion like they did in the first 3 years of life. We did like 5 different blood transfusions because the bleeding was so much, and you cannot take 100 polyps on a 1 year old. You can, but it's
So
cumbersome.
most of the time, after the surgery, you're going to be keeping screening the patient for the extra-intestinal issues or problems like endocrine problems, you say thyroid, or the testes, or the breasts, and in females, or the testes in boy. But often they would do well after
Absolutely.
the surgery.
Absolutely. And it depends again what I call it factory defect, what genetic disorder they have, because there are different categories. One is gastric, the GAPPS, gastric, the girl I told you. The other one is colon, which is a FAP, which is colon adenomas. Then the one that covers everything is the uh, generalized juvenile polyposis syndrome that gets got polyps in the stomach, small bowel, colon. It depends how much they have. You do stuff, but they don't have that risk of cancer like the other ones I told you. So the intervention to each one is tailored to what their needs are, what their risk are, and what their prognosis is, and then we monitor them and make sure they do well.
Again, I mean, almost at the end of this talk, and not to create panics among our population. So polyps we see relatively frequent in kids with rectal bleeding, uh, close to 100% of the time, not 100%, but most of the time they are going to be benign single polyps
And it's
that you
curative.
remove, and most of the times there is not going to be a polyposis syndrome
Right.
or anything like that.
Absolutely. Polyposis syndrome, the statistic is like 1 in 700 or 1 in 700, 1 in 500 kids has a polyp. And something goes away by itself. Something comes rectal bleeding, go to ER, pass a polyp, and you send it. The important is to get that polyp, take it to the ER, and send it so they can see what it is. Important thing is that the rare polyposis are by definition rare. The most common one is 1 in 5,000, 1 in 17,000. The other ones are even rarer. Okay, and like I said, my the way I look at it is in 36 years of pediatric GI, I had one GAPPS. I have 5 general juvenile polyposis syndrome. I have 10 familial polyposis syndrome, the one that colon cancer, and we have 2 general juvenile polyposis. I have one that has 7 polyps in the rectum, no other mutations. I see him every 2 3 years, and then just a different thing. And then I had hundreds of single isolated polyps, maybe two, and you take it out and it's over with. Okay. And in all these years of taking polyps out, I had two, and I happened to be a friend of the family, a musician that was with Willie Chirino. The mother went to school for me, college in school, and came with a 16-year-old kid. Took the polyp out, and I think that roughly 2 weeks later he had some bleeding, so I had to go in, put a clip on it, and the other just bled, but didn't have to do anything about it. And the risk of rebleeding and polypectomy extremely rare. Okay, and the risk of perforation extremely rare, and is unheard of. Okay, so good news, bright rectal bleeding. We have technology by doing stool tests to make sure there's no infection, inflammation, pus causes. Then we have a test to say there's inflammation called protectin, and that can be seen with polyps, Crohn's disease, ulcerative colitis, and cancer. And then you got to go at a good thing that we always use in our scale. That's why I take a long time with the patients. History. Any family member with polyps? Or you had polyps in Cuba? Get somebody to call and find out what type of polyp it was, what type of polyposis it was, what type of genes it was, hamartoma, adenoma. Just that information are helpful. And then put that together. And the one more clue, I have a great clinical geneticist, Dr. Miss Bauer. who has interest in polyposis, and together we publish in Kids with Polyposis, and she's our expert, and we cross cover each other for the genetic testing for polyposis. Now we send a panel, which before was only 5, 7 type of genetic. Now we have 30 different polyposis
Yeah.
genetic markers that we do
No,
on
and
a
I
blood
believe
test.
also that genetic testing nowadays is so easy to do. You don't even have to do blood testing or the
Exactly. It's
patients. I mean, saliva
saliva.
collection,
Saliva.
and that will be plenty of
Hmm.
it. It's very good, Jesse.
Okay.
I mean, I'm glad to have you as a former mentor and as a first speaker
Okay.
of this interview. I mean, we hope to keep on having many of these programs down the road.
And keep in mind, everybody, your friendly gastroenterologist is not going to scope you, but if you got rectal bleeding, we got a lot of things to do to find out what it is. And if we have to do it, we'll be gentle and, more important, safe, and more important, specific with diagnosis, because we're all being trained. And the important thing is there's a lot of new information that we're up to date, and we're very happy about it. I made myself be very strong to make sure that in our practice, we got this under control with all the different polyposes and stuff. I give the lecture for my fellows and residents on a yearly basis, and keep up to date what's new, and publishing it. And I think it's a good thing to have that. You are interested in liver, mine is polyps and others, and we all help us out in Pediatric Gastroenterology Associates for the best of our kids. Thank you
Excellent.
very much.
Thank you. Thank you very much.